Today I am going to discuss about hepatology journey of Professor Sheila Sherlok. She was a eminent hepatologist, first hepatologist, and I would like to discuss with outline of early career, important research publications, serving the society, and various awards and recognition to the Professor Sheila Sherlok. So she was born in 1918 in Dublin, Ireland, and after early schooling in Ireland, she went to Edinburgh Medical School for her medical graduation, and after struggling for around 1.5 years, she got admission in the same medical school. And post after the graduation from the Edinburgh Medical School, she worked with Professor Michael at Hammersmith Hospital, and there she worked on liver biopsy. And in 1943, she started to work. She worked on pathology of acute hepatitis, and they declined the theory of catarrhal jaundice. The definition of catarrhal jaundice was basically that all the jaundice is caused because of mucus plug at the level of ampulla, and this work was the basis of her thesis for MD at Edinburgh Medical School, and for this she also received a gold medal in 1945. She also worked in biochemistry and under Professor Long, and worked to isolate ACTH in patients with cirrhosis. Thereafter, she returned to Hammersmith Medical School after a year and joined as honorary consultant and physician. There she started to work in liver unit, and within few years of her work, her liver unit was famous, and she trained many fellows from UK and US and other countries, and published many papers on critical issues with excellent citations. So her typical interest was in pathophysiology of portal hypertension, portal circulation, and mechanism and management of hepatic encephalopathy. So at Royal Free Hospital, she worked with Professor Hill, who was interested for liver pathology and already working on acute alcoholic hepatitis. So they defined the term of acute alcoholic hepatitis at Royal Free Hospital, and at the same institution, she worked in collaboration with Professor Peter Shore, and he was also a pathologist. And at Royal Free Hospital, she did many important publications. First time they linked hepatitis B virus with occurrence of hepatocellular carcinoma. And also this is the first group who studied about role of sexual transmission and male homosexuality about hepatitis B transmission. So this first study that linked hepatitis B with hepatocellular carcinoma, published by her group of 17 male patients with chronic liver disease, surface antigen positive, with various form of hepatitis B, and 5 of these patients developed hepatocellular cancer with high alpha fetoprotein. So this is the first paper who discuss about role of hepatitis B to development of liver cancer. Her keen interest was to work in primary biliary cirrhosis. That time it was termed as cirrhosis, and they defined the role of antimicrobial antibody as a test for primary biliary cirrhosis. So this study of 200 patients, they did AMA test in various etiologies of cirrhosis like biopsy prone PBC, alcoholic cirrhosis, cryptogenic, and even they have included the patient with extrahepatic biliary obstruction and drug induced liver injury. So they found that PBC was universally positive in sera of the AMA was universally positive in sera of PBC patient. In PBC patient, and it may be false positive in patient with extrahepatic biliary obstruction. It was found in around 10% of the patient. So she also worked about role of portal decompression in the form of tips with patient with primary biliary cirrhosis. The patient, the total population was 25 with PBC and presented with recurrent varicose bleed, and they did percutaneous portal decompression and followed the patient for 51 months. and found that 5 of these patients die in the post-operative period because of multi-organ failure, and overall survival after portal decompression was 66%. That was comparable to other etiologies of cirrhosis, and it was depend on the class of CTP class of the cirrhosis. Higher survival in A and B cirrhosis as compared to CTP class 10 C cirrhosis. So this group, because of high copper content in liver biopsy of cholestatic disorder, this group also work on chelation treatment with cholestatic disorder like primary biliary cirrhosis. So they have used trine, that is a copper chelating agent, and this pilot study of 6 patients with a dose of 1200 milligram. They showed that there was, although there was increase in the copper excretion, but there was no clinical benefit of the copper chelation in the PBC, and there was many adverse effect was noted. And same group studied about role of D-penicillamine in the PBC patient, included 55 patient. This was placebo controlled trial in stage 3 to 4 stage PBC patient, and found only minor adverse events, and noted low mortality in D-pen treated group as compared to placebo group, and improved survival. Improvement of the survival was noted after 18 months of follow-up after D-pen treatment, and repeat biopsy done at 12 to 72 months showed that D-pen group had less inflammation in the liver as compared to placebo group. So role of cholestyramine in the patient with in the patient of pruritus because of intrahepatic cholestasis. So they shown that around 27 patients with non-obstructive jaundice, 17 had PBC, treated with cholestyramine for 6 to 32 months. They shown that it improves the pruritus in 23 patients, and withdrawal of cholestyramine leads to recurrence. Restart of cholestyramine shows against resolution of the pruritus. This the same group studied about studied about role of immune suppression in patient with PBC. So this placebo controlled trial of 45 patients divided the patient in two groups. One group received azathioprine at a dose of 2 milligram per kilogram. Another group. So this group, the role of azathioprine in PBC patient of 45 patient at a dose of 2 milligram per kilogram per day with comparison to placebo. They showed that azathioprine treated patient has less pruritus, but simultaneously there was significant decline in the liver enzymes, but there was no benefit in the form of survival after 6 years of the treatment in the azathioprine or placebo group. Coming to autoimmune hepatitis, this is the first group who studied the role of steroids in autoimmune hepatitis, and has shown the benefit of steroid in AIH. This placebo controlled trial done by the same group and included 44 patients in the duration of 48 months and followed for 72 months, showed that there was significant decline of the liver enzymes and bilirubin level at the follow-up of 6 months, and also there was significant improvement in the survival. Only 3 patients of corticosteroid group died at 72 months of follow-up as compared to 15 patients in the control group at the 15 months of follow-up. Hepatic encephalopathy was one of the important area of research about from this group. So they compared the induction of hepatic coma with subcutaneous use of opioid analgesic morphine, and they grouped they studied the role of morphine in induction of the hepatic coma, and they grouped the patient in two groups. One group cirrhosis without previous encephalopathy. Group B had cirrhosis with previous history of encephalopathy. They used subcutaneous morphine in the form of dose of 8 milligram or 16 milligram, and they found that 8 milligram dose had no effect in patient who previously doesn't have encephalopathy, but can induce encephalopathy in patient who previously had encephalopathy, and 16 milligram can induce encephalopathy in patient with or without previous history of encephalopathy. They have also documented neuropsychiatric complications of portal anastomosis in around 21 patients, and they shown that neuropsychiatric complication of portocaval anastomosis was higher in the advanced age group as compared to second or third decade of age group of the patient. This group was the first who showed the role of bromocriptine in the patient in the treatment of chronic hepatic encephalopathy. So, a small study group of 6 patients, and all patients had abnormal EEG with chronic hepatic encephalopathy, were not improvement on the classical on the low protein diet and laxative or neomycin, and they started bromocriptine for at the dose of 15 milligram per day, and followed over 8 weeks, and this was a crossover trial. So they shown that all patients who received bromocriptine showed significantly improvement in the clinical parameters like mental state, speech, gait, tremors in coordination, and overall response to the bromocriptine. And there was no obvious adverse effect was noted in the bromocriptine group, and simultaneously there was improvement in the cerebral blood flow in the 6 patient, improvement in the glucose consumption, brain glucose consumption, and also improvement in the cerebral oxygen consumption in the bromocriptine group as compared to placebo group. So bromocriptine can be used safely. So conclusion of the study was the bromocriptine can be used safe, and it is effective in reversal of chronic hepatic encephalopathy, but its role was not evaluated in patient with acute hepatic encephalopathy or recurrent hepatic encephalopathy. Same group also studied about management of acute encephalopathy, particularly in the patient with acute liver failure, role of blood exchange. Total 7 patients were included, and all patients have documented improvement in hepatic encephalopathy, although they died because of complications in the form of sepsis, AKI, and multi-organ dysfunction. Portal hypertension was one of the important interest area of Professor Sheila Sherlok. They used to measure portal pressure directly through the splenic pulp puncture or hepatic or the transcutaneous puncture of the liver and cannulation of the hepatic vein. So the role in patient with portocaval anastomosis, in the patient with recurrent GI bleed, they found that a patient who had a drop in the splenic pulp pressure, drop in the portal pressure and wedge hepatic or pressure, they had a less risk of development of further GI bleed. Splenic flow and resistance in patient with cirrhosis before and after portal caval anastomosis. So they showed that after portal caval anastomosis there was significant drop in the blood flow in the spleen. There was significant drop in the resistance in the splenic blood flow. Percutaneous transhepatic obliteration of the gastric esophageal varices was also published by this group, and they used to do percutaneous transhepatic portal venous catheterization to obliterate the major blood supply of the varices. This study included 13 decompensated cirrhosis who had continued bleed despite conservative management and endotherapy, and obliteration was achieved. The hepatic obliteration was achieved in the 7 patient, and they showed no recurrence of the bleed after adequate obliteration. So they studied about role of propranolol also. So this was a randomized controlled trial in the patient with decompensated cirrhosis and recurrent varicose bleed. So this group showed that despite decreasing of the optimal reduction in the pulse rate, there was no decline of the wedge pressure and free hepatic pressure, and simultaneously this benefit was not achieved in decrease of the varicose bleed, and there was no difference in the survival in propranolol and control group. Same group studied about effect of pitresin on splanchnic circulation. They categorized the patient in 3 groups. Group 1 consists of subjects without liver disease. Group 2 consists of 10 patients with portal cirrhosis and without portal vein thrombosis. Group 3 consists of patients with cirrhosis with portal vein thrombosis or either portocaval anastomosis. So they shown that pitresin injection was associated with significant decrease in the hepatic blood flow, increase in the splanchnic vascular resistance, decrease in the portal venous pressure and wedge hepatic pressure, in the normal, in the cirrhotic patient without portal thrombosis, and cirrhotic patient with portal vein thrombosis or portocaval anastomosis. Coming to HUTO, they published a series of 19 patients between the follow-up of in between 1965 and 72. So they used to do hepatic scintigraphy to diagnose and classify Budd-Chiari syndrome. Ascites was one of the important area of research. This article showed that management of refractory ascites with one or two combination of diuretics. They included the patient on the combination dose of diuretics, including chlorothiazide and spironolactone and mannitol. They showed that combination of three in the form of chlorothiazide, spironolactone and mannitol had better mobilization of the ascites as compared to single diuretics. So this unique modality of treatment of refractory ascites was published in Lancet in 1974. They shown that they use automated ultrafiltration device for management of ascites. They used to remove the ascitic fluid with a pump and use a ultrafiltrate that concentrate the protein, and they used to re-infuse the same protein in the peripheral vein, and they showed that that reinfusion of the protein concentrate in 17 patients with diuretic resistant ascites. The procedure was well tolerated, and there was no change in the serum sodium, and there was little improvement in the blood urea, and ascites was well controlled in all the patients, and there was little improvement, significant improvement in the ascitic fluid albumin. The portopulmonary anastomosis was studied with krypton radioactive scan by this group, and they correlated with arterial oxygen saturation with various degree of portopulmonary anastomosis. Kidney dysfunction was described as portal systemic nephropathy, and this is the genome washout scan of the normal individual and patient with cirrhosis. So this is study of 33 patients using a gamma camera nephrogram showed that the patient with cirrhosis with or without ascites, there was moderate to severe reduction in the genome washout in patient with cirrhosis and ascites. Other publications, there are total around 760 PubMed listed publications, and published in leading journals like gastroenterology, Lancet, Gut, NEGM, and hepatology. Mainly focus on hepatic hemodynamics, portal hypertension, PBC, autoimmune, PSC, Wilson, alcoholic liver disease, and pregnancy-related liver disease. She chaired many eminent societies. She was the first woman to chair of a British Department of Medicine at Royal Free Hospital School of Medicine, and she became one of the youngest women that was elected fellow of Royal College of Physicians, and she also chaired the senior censor and vice president of the same society. She received a prestigious award like a British Society of Gastroenterology, and she edited Gut Journal for many years, and she also received the award of Dame Commander and elected as fellow of the Royal Society in 2001. She wrote many books, and one of the important book was Disease of Liver and Biliary System, that first edition was published in 1955. First 8 editions were written by herself only, and the latest 11th edition was released just 2 weeks before her demise in 2001. So she retired in 1983, and despite that, she used to attend all the regular meetings of hepatology, EGL, IGL, and ASLD meetings. And after her demise, two eminent hepatology journals, Lancet and Journal of Hepatology, was published her biography in 2002. Thank you.